Not an NG.
No,
It's a Dobhoff. Okay? Dobhoff 2. It's like an NG,
How
but
do we spell that?
Dobhoff. I'm going to show you something really cool about a Dobhoff. When we place these, this is the little guy goes down. Okay? So when we take an x-ray, we know where it's at. So with these, you don't have to check placement. Okay? We know that it's there. You measure just like you do your other, but then you do an x-ray and you know where it's at.
so is that whited?
Uh-huh. You wanna feel this? Okay, just kind of pass that. Just kind of pass that around. That'd be cool. You wanna join in over here? I'm right. I can kind of. Okay. Do y'all know what this is? I'm gonna ask y'all a few things of what is what. Do you know what this is?
Suction.
It's suction. But look, you don't have to get your sterile gloves out. You're sitting there like this and hyperventilate because they're already on a ventilator. You just push that 100% O2 and you can go down in there. All of this is sterile. All of this is contained. And then when you get ready to suction, you just pull out, just like that. It will go into the drainage, into the suction. You'll have you'll have tubing connected to suction. It goes right into the suction.
How do you know how far to go in? So do you make resistance? Or?
Well, he's got an oral airway. You can go down pretty far with this, okay? They'll start coughing just like they would with the other. You start pushing this down through here like this. We're gonna make some resistance anyway. Let's see how far that can go down. And he starts coughing.
So all the way.
All the way.
Continuation.
All the way down.
Now, do we
Okay?
have to put fluid in there? Like, I've seen respiratory do that a lot, like they'll put like 10
If they have got, if they're dry, especially with trachs, you'll get a mucus plug. Y'all know what a mucus plug is? It's where you get that hard piece of mucus in there, and you'll notice when they start doing it because their stats start dropping, and they'll start kind of having a hard time. You'll see them trying to breathe if they're kind of more alert, and sometimes we have to bronch them to get those things out. So technically, but according to our scope of practice, we're not supposed to do that.
Okay. I don't know if we could, since I said just
But-
respiratory, that's what I was asking.
But real world, yes, we do. I'm not gonna wait for respiratory to come and do that when we're dropping down in the 80s and 70s, so. And it's out. Okay, let's see, what else here? Something else magical you see. Look at this. Y'all know what this is? Look where it's connected. It's connected to the, see what it says art? This is arterial line. Now y'all may have studied this in cardiac, right? We put these in our burn patients because we want to continuously monitor our burn patients' blood pressure, because why? That's a big sign of shock. We need to know if they're going into shock, right? So we'll hook these guys up to the monitor, and this is exactly what they look like. This plugs into the monitor right here, okay? Now, if I need to draw blood, this is the cool thing. Like if I need to collect labs, all I do is I'll clean this off here, pull this back, turn it like this, and put a little vamp on here, and I think I have a couple little vamps. I don't know what I did with them. That's okay. But you'll put like a little vamp on this, and you can get your blood, and you're done. You can get your ABG here. So that, that's kind of cool that you can do that. I'm just showing y'all some stuff that if you go in ICU, you won't feel so as intimidated, because this stuff can intimidate you. Look at this. We're going to put this into a patient with a major burn. This is actually a 5 lumen. Okay, it's like having 5 IV lines in one line here. Okay, we can hook 5 different things up. Why do you think we might do that?
For TPN.
Meds without.
Oh my goodness, this guy right here, as bad as his burn is, he's gonna get IV fluids. He's gonna get albumin probably. He's gonna get electrolyte replacements, because remember what I said, their electrolytes are all hanging out and they lose those electrolytes. So we need to put those electrolytes back in. You will give a lot of replacements. You'll also give a lot of blood. We give a lot of blood to our patients because they lose that volume. If his blood pressure starts tanking, we might give a little bit of Levo. And what do we need to tell our patients about Levo? What's the thing that you remember about Levo? Levophed, leave them dead. You remember it clamps off. You know, it's one of those drugs that clamps all our little bitty like our little bitty capillaries. And so we need to look for what? Capillary. They may lose their fingers and they may lose their toes if they're on it long enough and on a high enough dose of it. They can make everything clamp up because we want that blood pressure to stay up so everything is centered around the heart and the brain. Okay? Let's see, what else do we want to know here? CVP. Do you know why we do CVPs?
See how much fluid is on board. To see how much fluid is on board.
Fluid status. Exactly.
She was saying it.
You said it.
I said it first.
Okay, so we monitor a CVP. CVP for us is normally connected to a line here. There's two ways you can monitor a CVP. You can monitor it through a Swan Scans. We don't do Swan Scans. We do what we call a LIDCO. I love LIDCOs for the simple fact that you just connect it to one of their lines here and it connects to a machine and it reads everything out for you. There's no wedging or anything like that. Now, what is a normal CVP?
2 to 6.
2 to 6, right? Well,